Hi, I'm Francesca Morrell, and I'm a senior studying bioengineering on the pharmaceutical track. This is my third year conducting research in Dr. Emma Murthy's lab. My research focuses on morphometric analysis of elastic matrix structural changes in abdominal aortic aneurysm patients. Abdominal aortic aneurysms, also known as AAAs, are gradual expansions of the abdominal aorta over a period of time, leading to a fatal rupture. AAAs are characterized by breakdown of the extracellular matrix metalloproteinases, also known as MMPs, and compensatory collagen synthesis. However, due to persistent inflammatory and proteolytic environment, collagen also undergoes proteolytic degradation, leading to increased stress in the vessel wall over its strength, leading to rupture of the aorta. Currently, there are no drug-based treatments of AAAs, and surgical repair also does not help in restoring the structural integrity of the aorta. In order to develop any strategies for regenerative repair of the elastin, understanding its morphological features in the AAA environment is critical. Most of the prior morphometric studies have only quantified the percentage of elastin fibers in the tissue, but not other critical parameters like diameter, perimeter length, and tortuosity. Therefore, in this study, we have used a computer-based morphometry technique developed in our lab to quantify these critical parameters in the tissue samples collected from AAA patients undergoing surgical repair. The goal of the project is to compare the demographics of the patients and perform morphometric analysis of the elastic fibers in the tissue. Tissues of patients were collected from Cleveland Clinic, Heart and Vascular Institute. Tissues were paraffin embedded, sectioned at 5 micrometers, and stained with a modified heart stain, which stains the elastic fibers in purple. The stained sections were scanned using Lucia whole-size scanner, and morphometric analysis was performed at each section using ImagePro software. Morphometric analysis was done according to our published method. In brief, the images were spatially calibrated and region of interest was defined as the entire section. Pixels corresponding to elastin based on color of stain were selected, and the selection of elastin by color range and density was extended throughout the region of interest. The selected elastin pixels were defined as objects, and the following morphometric parameters were computed: angle, area, percent area, maximum diameter, minimum diameter, perimeter length, and tortuosity. Comparisons were made for differences in average values for area, aspect ratio, and perimeter length, totals for percent area, and measurement variability for angle and minimum and maximum diameter. The tortuosity is predicted to change shape after aneurysm and change with age, shown in previous publications. It can be assumed that the tortuosity will change in a similar way into more of an S shape. The darker regions on the tissue sample is shown. Parameters such as area, aspect ratio, diameter maximum, diameter minimum, percent area, perimeter length, perimeter bounding, and tortuosity are compared to different demographics. The demographics include gender, smoking history, thrombus, atherosclerosis, diabetes, and chronic kidney disease, and their effects on the elastin. That is measured and compared using the different parameters. The focus for the study is males because of the increased amount of samples in the data set. Figure 2 shows the breakdown of the demographics gathered from the REDCap data. Figure 3 displays an image of the tissue sample that was uploaded to the program for analysis. Figure 4, the data shown focuses on the statistically significant graphs, while Figure 5 is broken down into a weighted system for analysis. For example, some of the patients have atherosclerosis and diabetes, while others may just have one or multiple of the parameters that are being focused on from the REDCap data. This allows the impact of the parameters from the REDCap data to be analyzed further in terms of the parameters from the morphometric analysis. Demographics data suggests that male patients are definitely more vulnerable to develop AAAs than females, and smoking is a major contributing factor for the development of AAA pathology because a total of 84% of the patients have smoking history, either present or past. Atherosclerosis is 88% patients is in agreement with literature describing pathophysiological progression of AAA, since atherosclerotic plaques block the entry of nutrients to the cells, leading to cell death, elastin degradation, and progression of AAAs. Studies shown that progression of CKD in AAA is attributed to common MMPs like MMP289D2. Hence, it is more likely that CKD can lead to AAA or vice versa. We compared the morphometric data between the patients with and without AD in this work because AAA is followed by AD in many patients because severe aortic bulge increases the risk of a tear in aortic lining, creating a false lumen and leading to AD. So we wanted to see these changes in the elastic fibers with increasing severity of aneurysm. Increased percent area of elastin, shown in figure 4F, suggests more fragmented elastin in the patients with AD, while no difference in mean was seen in other parameters. The data trend shows higher variability of critical parameters like diameter max and perimeter length, suggesting some pathological changes in the elastic matrix with the presence of AD. Future work includes gathering more tissue samples from St. Luke's to expand the data, as well as develop a database using AI to input this data to predict when patients would need to undergo surgery based on these demographics and parameters. I would like to thank Dr. Murthy, Shitakshi, and my entire lab, as well as the Lehigh Bioengineering Department, David and Lorraine Freed, undergraduate research members and associates, the National Institute of Health, and Cleveland Clinic Heart and Vascular Institute. Thank you.